All right, guys, good morning. My name is Sally Alrabaa. One of the clinical attendings here in infectious disease. I came to USF like you as a fellow 15 years ago, never left. So welcome. All right, the topic today is it's a huge topic. We're gonna try and just learn the landscape over the next hour or so, and then we'll take some questions and things like that. Um, it's a part one of two. We will do two sometime during the year. But infections in solid organ transplant recipients, the very ambitious learning objectives for today. Understand the factors involved that increase the risk of infection in solid organ transplant recipients. Recognize the timeline of the different types of infections post-transplant. Recognize the specific infection types associated with different immunosuppressive agents. Meet some of the common infections or common organisms that we see in this population. And then a very, very general approach to diagnosis and management. As you can see, every point is probably like a whole hour of discussion, but I guess the purpose is just like a 30-foot overview of like what's happening there. All right, to start with, the patient who is pre-transplant or post-transplant is immune compromised in many levels. If we remember, you have your innate immunity, your adaptive immunity. The innate immunity, you can like skin, mucous membranes, the internal defenses like phagocytes and the natural killer cells, and you have your adaptive defenses, which is your B and T cells. So the transplant patient is compromised in all of these levels. So you can understand that even though sometimes we talk about specific infections with certain immune deficiencies, if they have mainly T cell medication or mainly B cell medication, you can still understand that a variety of different infections can still occur, and because of this continuum. And these are just basic stuff. I like to go because you're gonna see it, coming up often. The outcome of infection and rejection, infection in transplant patient is the result of what we call the net state of immune suppression. So the best team is the team who can use immunosuppressive agents just enough to keep the organ alive and working, prevent rejection, but at the same time you leave some immunity to for the person not to be predisposed to a lot of it. There's a fine balance. Many times in the patients you see, especially the hospitalized patients, is like it's all tilted. Either they are rejecting on a lot of immune suppression, and then you have very high risk of infection, or the opposite, they are not tolerating drugs. And but usually the net state of immune suppression, it's a conceptual the evaluation is very subjective because we still do not have very specific labs or measures that we can say this person is at this degree of immune suppression, but you kind of evaluate it through what organs they got transplanted, what immune suppressions they're on, what are the doses, are they going through rejection and we have increased immune suppression. Also, are there predisposing things to infection? Do they need ports, dialysis catheters? Do they have open wounds? And do they have other organ dysfunctions, chronic renal insufficiency? Are they having like metabolic problems and controlled diabetes? And also if they have concomitant viral reactivation. And you will learn that as you see these immunosuppressed patients, sometimes they have, chronic CMV or activation of like HSV, or all these viruses also affect the immune system in various ways. They may potentiate onset of other infections, or they may exacerbate to rejection. So as you can see, when you're approaching that patient, you're thinking, how immunosuppressed are we talking about? And then these are the factors that you have to think about. So how do we approach this thing? I mean, it's these people are predisposed to a lot of variety of things, from your usual infections all the way to the zebras and uncommon infections. So we like to think about, what is the epidemiology and causes of these type of infections? Where do they come from? So the first thing that you may see is like in your regular patient, they just received an organ transplant and they may be suffering from complications of surgery, surgical site infections, bleeding, hematomas. They can also get healthcare associated infections very easy. So you cannot think of the context. Did they just have surgery? Are they still in the hospital? Did they just leave the hospital? Community acquired infections, have they been out for a while? Did they travel? All that stuff. And if they are at a stage where they can have reactivation of old infections, OI, or is what you're dealing with is donor derived, has really nothing to do with your recipient and where they've been and if they had surgery or not, and if this is a donor related. So the timeline, like when we were fellows till now, kind of has changed because people got better with the immune suppressive regimens they're using, the antibiotics prophylaxis and so forth. So, what we're going to discuss is, again, just a broad, common things are common, but then things may change depending on, are they on multiple antibiotics for completely different reasons, or if they, cannot tolerate any antibiotics and so forth. The causative agents are your usual classes. We see the most common are bacterial infections. And again, you're going to see your hospital-acquired, your MRSA, your VREs, your C. diff, all the way to less common like Mycobacterium tuberculosis, nocardia, and even rare ones that you don't see in your immune competent like Rhodococcus. The fungal group, Candida is probably the most common, followed by molds like Aspergillus and Mucor, and then of course the yeast Cryptococcus. Viral infections are also very common, especially the herpes group, the HSV1, HSV2, CMV, and varicella. CMV is a big one. Like if you say like there is a pie of infections in transplant patients, like CMV will have like its own quarter. Like that's, this is all CMV, and then the rest is shared with all. So you will see CMV very often. You have always to think about it. It's very tricky because not every time you see it, it's causing a problem. But when it's causing a problem, it's very problematic. So the evaluation of these patients should take into consideration what organ they got. Did they get just a kidney, or they got a big, messy operation with a liver or a lung? Pre-existing infections. Sometimes these recipients may go in with some sort of a chronic infection. They may have a MAC or something else. And then exposure. Do they have, cats? Have they been outside? That's a true story. A heart transplant patient who was a garbage man. And then after he got the heart, he healed, was 6 months, just as of he coming off prophylaxis, he went back and resumed his job. And then a year later, he came up with a big fungal ball that he had to have a full resection. So exposures are very important. Are they taking any antibiotics prophylaxis? Because it may change, just like with the era of like HIV before Bactrim, everybody had PCP, and now you see PCP only in people who are not taking Bactrim and so forth. So taking prophylactic antibiotics also has to be considered. The graft function. Is this kidney, is this liver like really working? Because dysfunctional organs will affect immunity, will predispose to infections locally and other sites of the body. And again, the overall immune suppressive status, how much they need, and did we need to redose them of like high induction doses because of rejection? So this is the general approach of, did they have an infection before, what organ, what's happening afterwards, what exposures, what kind of drugs, and so forth. Now, to the other lecture that we're going to talk about is a mitigation. So if we know all this, can we do something pre-transplant? And that talk is screening and prophylaxis. We will talk about another time. All right. So talking about epidemiology and timeline, so we kind of knew what kind of bugs, but also there is some like rhyme and rhythm to when they occur. Can anyone guess what type of infections, organisms do people see in, or people get, solid organ transplant recipients get in the first 30 days, the first month? They just got the organ, they, maybe they are still in the hospital, they just left the hospital. So if they call you with a fever or a high white count, what are, again, we're talking probability, just like incidence.
Surgical site infections?
The regular surgical site infections, nosocomial infections, you're going to approach this patient, you're going to look at their wounds, do they have lines, follies, because these are the things you will encounter. Can they have the zebras? Sure, but really that's not the timeline. So the things that top the list is surgical site infections, healthcare associated. If they had a heart or so, sometimes it can be deeper. You may not, the wound may look very good, but you touch it, it's a little tender. So you kind of have to be careful assessing the surgical site because it may not be obvious right away. Bacterial infections, be careful with resistant infections because remember they are in and out of the hospital before transplant. So you have to factor that in. If they did not start like antifungal, sometimes things like fluconazole for liver or kidney people may not, and they have like a line or something, then candidemias. So you have bacterial infections, candida, so regular stuff. The only, like, I can't call it opportunistic, but something that may reactivate is herpes. Sometimes they can have outbreaks of HSV. And then that's the time where you want to consider, is it donor transmitted? Because, and it happens in the donor world every day, somebody dies with an unrecognized infection, or maybe they did die with a recognized infection. And then regardless of what, that's the only time where you see, for example, an infection like TB appearing in the first 30 days, because usually things like TB and other mycobacteria take time to develop. But if they were active in the donor and you got an organ that had TB in it, then you may see some organ transmitted. Thankfully, organ transmitted infections are not very common because of the screening and all that. But it is something that we see now and then. Not too long ago, I think 3 months ago in January, that we had the rabies transmission. Rabies, yeah. The guy, I mean, you can look up the exact story. Someone died in like an accident or something, and they were confused before they were in, And then he gave multiple organs and corneas and tissues, and people who got non-sterilized tissues like organs and developed rabies. Thankfully, corneas are not usually irradiated. They're usually like minimally processed. That particular cornea, that process irradiated, I don't know why. And the cornea recipient did not get it, but the liver got the. So it does happen. As you can see, when it happens, it gets the news, but it's not very common. So now that we are after the 1 month, now we're talking about this from month 2 to month 6. What do you think happen, kind of infections, and why? Now you're in this, like, they left the hospital, they're home now.
That was nice of him. Do you think polyoma?
Not yet, but good thought. Reactivations.
Yeah, that's the period of like maximal immunosuppression.
Exactly. So now they left home with with all kind of immunosuppressive agents. They got all these high doses of induction, and now we're sending them home. They are still trying. The transplant physician's main goal right now is that graft is alive and it actually grafts and function. So maximum period of immune suppression, they have not yet titrated down. If anything, they may titrate up if they see the LFT is a little bit high or something. And then here is your OIs and zebras and all the unusual. So someone comes in sick 3 months into a transplant, that's serious. You really, that's where you're going to spend the time. From the 15 patients you have to see, that patient will probably need an hour, 2. All right, so you see the atypical. If they haven't been able to take things like Bactrim, common things are common, PCP, toxo. And again, you will learn in the other lecture that prophylaxis is very effective. If they are able to take it, then you shouldn't really see PCP and toxo. Nocardia, and then CMV. If they're not on prophylaxis, and there are ways to prophylax against CMV, you can just follow the levels, or you can put them on medication depending on the organ and the center and all that. So, but these are the usual. You think about CMV, you think about some opportunistic infections. That's when fungal infections also can appear. If they have a nodule or a mass, then you're thinking aspergillus and all that. And again, things like tuberculosis, especially if they're donor derived, they may start happening 3 months into transplant. We had a lung transplant patient who it was not known that the recipient had like nodules, was like active TB, and he developed TB. He came in with a pericardial effusion. That's how he presented. So things, and then histoplasma. If you, so this is kind of so you're considering still the MRSA and the usual stuff that we look for, but now you're kind of paying attention to it can be nocardia, and that's why Susan said I like the curious. Like, how long are you going to wait for a nocardia culture? Absolutely not. You're curiousing that. But interpretation is you have to be careful how to. So, now say that they're now fine, they're 6 months later, they come in with suspected infection, fever, or anything. What are you thinking?
C. diff.
Community acquired. So after the first 6 months, now they transplant doctors figured out because their goal is to keep them in the minimum immune suppression that actually allow the graft function. So now that if you have two pathways, either the graft is doing great and now the immune suppression is low, and now this patient is a good state. Now you're looking at more of the usual community acquired, or he's been suffering and they've been reloading and redosing and all that. So really the outcome after that depends on what's happening to the graft and the immune suppression. So if they're doing good, you're looking at your usual community acquired. You see people coming with influenza, COVID, just the usual, strep pneumo for lungs. Otherwise, regular bacterial infections, UTIs, if they have a Lyme, staph, MRSA. But then if they have dysfunction and stuff, then you have to be careful with the zebras. It can be literally anything. If they're very immune suppressed, graft is not functioning well, then you really have to expand your workup and look for and not take things at face value. This, the common wisdom, if it looks like something and you see it, and you have to be very careful with this particular population. They've been immune suppressed for a long time, and things may not appear, very quickly, may not be apparent. So you always have it back in your mind that this could be, and that's the patient who may have two things. Usually they don't. Usually it's one problem that's causing the symptoms and all that. But when you have, such a patient in a difficult immune position, then you may see that. So in general, what we see, people who get the clean surgeries, the heart, the kidney, they do a little bit better infection-wise from people who get, of course, lung is the worst, and then liver. So usually kidney folks they do reasonably well apart from their UTIs. Heart next, but problems can arise, and zebras can happen in lung and liver. And that's when also you can see reactivation. That's when the shingles and the disseminated varicella or very bad zoster can happen. The EBV, now you can see the lymphoproliferative disorder or PML, GC, they come a year later, they're a bit confused, they're clumsy, and then you have to think about these unusual now, even those who are doing great on minimal immune suppression 2-3 years later, these are still not really normal immunologically. So even though we can minimize the risk significantly, it's never really gone. Or like a 50-year-old not immune suppression and somebody on low dose of immune suppression are very different. I put this slide because just a famous slide since the beginning of the understanding of and you will see it. And all it says is just summarize what we just said. So you have your first month, you can see your nosocomial, your technical, is it donor derived? You go in the middle 6 months and you're looking at opportunistic infections, the usual offenders are right here. And then after that, you can see from, as I said, from the usual all the way to the zebras and long-term. Things to consider again, are they rejecting, or are they neutropenic because of immune suppression? Do they have a chronic viral reactivation syndrome? Yes.
tacrolimus.
Mhm.
How long do you expect that time period for them to have increased OI infections? Like we're not going off this chart.
Yeah. So it's I think I don't know the exact numbers, but all I can say is that it's drug dependent, and that's why I have one drug slide, because here's the thing: these drugs, uh, the new stuff coming in the market, they use them in different combinations. I would encourage you highly, once you approach your patient, you do exactly that. You look at their drugs, how long they've been on, and then you read about the side effect profile and when. Some drugs cause neutropenia pretty quickly, within 3-4 days. And once they hit neutropenia, they are at risk for whatever neutropenic patients get, the gingivitis, the translocation, all that. Some who act by decreasing the B and the T cell may take a couple of weeks and so forth. It is a spectrum. I don't think it's a very it's drug specific. So this is probably would be something that you probably have to look at their combinations, what they're taking, and so forth. I mean, it goes without saying, the longer they're on it, the more likely. And this is the list I have. I stole this from Jay Fishman from Mass General. So these are the common things now, and things may change. So if they have, this is usually used, the anti-thymocyte globulin, the T cell depleting antibodies are used a lot during induction and the first phase. These are really, really immunosuppressive drugs for the T cells. And that's when they can get readmitted and they reinduced, and now you have uncontrolled herpes or zoster, and then the herpes is like eating their lip and so forth. So the opportunistic latent infections that are usually controlled by T cells, that's what you want to pay attention to. They also do this cytokine release syndrome, and 50-50. Sometimes they call you for like sepsis, but it's really the drug. So it's, again, you always have to play the devil advocate and pretend it's infection till you're convinced it's not. But I want to say, in my experience, like half the time it's really not. It's the drug, but it is a diagnosis of exclusion. If they are on high doses of steroids for a long time, then they should be on PCP prophylaxis. If not, then PGP, especially when they're trying to taper down. It's a very common things are common. You're going to see it. And then, of course, if they have chronic infections like B and C, that's when they can get out of control. Azathioprine has something with human papillomavirus. Now, this list is not exhaustive in any way. These are like associations. Like if they are on a lot on this drug, then these are the things that you see. Doesn't mean that you can't see other things. You can, but it's just one of those things that you have to keep in the back of your mind. Human papillomavirus, they can have, if they have lesions, it can get really out of control in azathioprine. Things like cell septic neutropenia, and this can happen pretty quickly. And then you have your usual bacteremias, and then that's where CMV can also tacrolimus, gingival infections, intracellular pathogens, rapamycin, that mTOR inhibitor. They are notorious for poor wound healing. So if they call us for the wound is oozing, and then you see this drug, that there is this significant effect on wound healing. So the treatment may not just be like clean it and give them antibiotics. It's probably and also it has also this pulmonary syndrome, like bilateral infiltrates, and you feel like there's like pneumonia or like COVID or something, but it is the rapamycin. Belatacept, Epstein-Barr, PTLD, rituximab, again, the buzzword is hepatitis B. If your patient has chronic hepatitis B and they're going to go on rituximab, you better make sure they're prophylaxed against it. And eculizumab, which is Solaris, inhibits the terminal complement system. So encapsulated organisms think like they don't have a spleen. So these patients have to be immunized and also have to go on prophylaxis if they're against Haemophilus and Neisseria meningitis. And then people who are getting frequent plasmapheresis, you're removing all the elements and, encapsulate bacteria. This is just a snapshot of like common things are common, but again, not exhaustive. If your patients are on one or a couple, you kind of have to brush up on it and see what, and there is always a new warning sign that something's up with the drug. So if we're gonna zoom in a little bit and see what kind of infection syndromes happen in the different organs. So you can guess, kidney, at least one infection episode per patient. And from all patients who got, the infection, you will see about 10% who actually got it with a bacteremia. CMV disease, 8 episodes, for or 8% of the infection episodes were related to CMV, fungal infections, and the common source, UTI. So that just gives you an idea. So bacterial infection and bacteremias are common in transplant patients. CMV, it has its own column. So, and then fungal infections, and then you have the common sites. If they have heart and heart-lung transplants, look at the lung. They usually, they come in febrile and all that. They may not have significant symptoms of cough. Scan the lung. You may, find your source there. Liver, again, the most common source would be the biliary, right? Abdominal biliary. So it's just you start by the site where the organ or the surgery had. You start there, and then you expand your evaluation. The good news, if you see infection episode, deaths from infection by organ, they're all trending down. You can see kidney is probably the least problematic, and then the rest are high up there. But because of the screening and prophylaxis and early evaluation, things like the Carious test, we diagnose things earlier, and then even though we're doing more transplant and the immune suppression drugs are getting so good, these people are living longer. The infection trends are trending down because of this organized systematic approach. So the general principles, and this is just, as I said, the 50-year-old coming in with, suspected infection, no immune suppression is one evaluation, but somebody who's in immune suppression, it's kind of take a different. So people who are in immune suppressive therapy have impaired inflammatory response. They may come in with these vague symptoms and no fever. You still have to think, can infection be the reason? So you always have to have a high index of suspicion when these patients get admitted or they have a complaint or a problem. And another big difference is that if there is a lesion or a abnormality in a radiologic image and all that, these are not the patient who you say, let's treat and wait. It most likely looks like that. I'm not saying in every case, but it's very important that we get as close and accurate microbiologic diagnosis as possible, because things can get out of control really quickly and can disseminate and all that. So kind of have a high index of suspicion and also a lower threshold to obtain imaging and do biopsies and all that. You may have to start empiric regimens of antibiotics because of instability, and if that's the case, you have to factor in if they received prior antibiotics resistance. Maybe they have been on CMV prophylaxis like Valside for a long time, and you're worried that this profuse diarrhea, CMV colitis, then you may have to change what they're on. So the approach to management, again, many times you need the evacuation surgical if they have a wound infection, if they have a collection under the surgical bed or things like that, that will probably need to be evacuated, antimicrobials. And then you have a discussion with the transplant surgeon how much immune suppression you can relieve by adjusting the meds. But sometimes you're in a hard spot because everything is just escalated because they're rejecting. So you also have to, you're doing all this, but you also have to put in your mind the non-infectious causes of fevers or things like that, the mimic infection. Rejection is a big one, and these immune medication is also sometimes cause like a SIRS reaction. So this is a general, I mean, it's a bit, you have a low suspicion, you're a bit aggressive, you're trying to really achieve an accurate diagnosis rather than early on if you can. So just now zooming in by organ, what do you think kidney transplant recipients get as, infection syndromes? Just probability. What do they come in with? UTIs, pyelo. So it is estimated, and I think this is an underestimate, by the third year of a kidney transplant, everybody had at least one like significant UTI. So you kind of have a low threshold or looking at them and treating them, because if it's chronic and recurrent, it can affect the graft function. So we're usually a little bit more aggressive. You could treat it as a complicated urinary tract infection. You want to get an accurate microbiologic diagnosis. You want to treat adequately. Now, nobody knows really what to do with asymptomatic bacteriuria. In this, and things may differ by centers. People just sit in a table like that and decide, when you don't have like a great evidence of like, what is your patient profile, what you've seen, what complications you had, and then design your approach. So asymptomatic bacteriuria and kidney transplant, there's really no great guidance for it. But in this center, again, the first 6 months, the team here is very aggressive. Like, they wouldn't refer to ID even. They will check for it. They'll screen. If they have asymptomatic bacteriuria, at least they know they get sensitivities and they get treated. After that, it gets evaluated and treated as regular. Some other center you may see, maybe they just follow. I don't know. It just depends of what, be careful of uncommon pathogens. So if it looks like, the graft site is tender, or they have frequency, they have fever and all that, and you have some pus in the urine, but it's sterile pyuria, you have to look at the atypical. We've had our fair share of TB in the transplanted kidneys, unusual organisms like mycoplasma, histo. Adenovirus causes a hemorrhagic cystitis. You will see it at Moffitt, even without kidney transplant. And then BK virus. These are latent viruses. They reactivate and can cause trouble, chronic infection and allograft dysfunction. They are screened for, and the treatment is really improving the immune suppression. There are antivirals, but the treatment is really reduced immune suppression. So these are unusual. Like, what else are you going to look for? When kidney transplant patients come in with other infections outside the genitourinary system, pneumonias, wound infections, especially if they had problems post-op, if they had, seromas, hematomas, things like that, then they may come back because there is something that needs to be evacuated. Again, these are, of course, they can get any other infections they want, but these are the common things that are seen. What predisposes them in the first 6 months? If they receive excessive immune suppression, a chronic allograft dysfunction, and they have chronic hepatitis of some sort for reason, chronic hep C, if the liver is affected and cirrhotic, they try and do like liver kidney. The patient is on dialysis, the liver kidney, but sometimes they will not qualify for a liver, and then you're living with a chronic hepatitis. So these are the type of patients that you kind of have to think, maybe they have recurrent UTIs, maybe it's atypical organisms and so forth. You're going to see this theme gets repeated over the organs with slight variation of, the infection side. All right. Heart. When they come with infection, what are the usual common things that heart? We got a heart transplant last year. They come in sick now. Pneumonias. Pneumonias are bad ones. So they can get their UTIs and all that stuff, but chest transplants, heart and lung pneumonias are serious, and they're not, unfortunately, infrequent. These needs to be, again, appropriate diagnosis, microbiologic diagnosis, biopsies, and you want to treat them aggressively. They can get UTIs. CMV, you're going to see it in every organ, but heart, lung, CMV is a big problem. it reactivates. It can cause organ disease, like it can cause pneumonitis, it can cause hepatitis, it can cause a generalized like flu-like symptoms and immune suppression, and then Aspergillus decided to grow up because CMV made everything just perfect. So these are the things that the common things that you start looking. You have to start somewhere and then go further. So most commonly, pneumonia bacterial is still the most common. Stanford did this study survey a few years back, and from 620 heart transplant recipients at Stanford, infections were the most common cause of death in their heart transplant. And pneumonia is a big deal. You know how like people here have a low threshold, they have a pneumonia and their patient's fine, afebrile. Pneumonias are like really, serious, and they even in the non-transplant, when you look at hospital-acquired infections, for example, the most serious, the one that has a high mortality is pneumonia, hospital-acquired pneumonia. All right, early common causes, your gram-negatives. This is where you see your Pseudomonas, but you can also see Staph aureus. Aspiration is common in these patients, and actually in the lung transplant population, if the person has a GERD, or they have to fix that first, because you don't want things aspirating in the lung and then forming nidus and problem, heart and lung. Less common, but you're going to see it, Aspergillus, herpes reactivation, we've seen Legionella, and toxo if they do not, if they have latent toxo or the donor has latent toxo and they're not, because once there is toxo, you have to be on chronic prophy, because there is a special predilection of the toxoparasite to the heart muscle. I just highlighted the things that you want to be careful with, the PCP, nocardia, Aspergillus, CMV, TB. Everything else is fair game. Anything from this list is possible, but you from the bacterial category, you probably want to look at nocardia, fungus, Aspergillus, viral, CMV, and of course, always be careful about TB. Okay, so heart transplant people, well, and on lung too, have some unique infection predisposition because of their situation. They can get the mediastinitis because of the deep, prolonged surgery. So very important that you always evaluate the chest for mediastinitis, sternum, the lungs. And common things are common. When we do find them, it's usually your staph and, Pseudomonas, they're usual. But we've had an atypical organisms. We have Mycoplasma, Aspergillus, we had Mucor, Nocardia. These can still cause subacute or chronic type of mediastinitis. So if your regular bacterial culture doesn't grow anything, that's not the end of the workup. You really need to, if they had repeated operations or increase in anti-rejection, or they're just poorly controlled diabetic, that's seen even more. If mediastinitis is suspected, you need to involve the surgeon, because a big component is, of course, IND and getting really good OR, micro and path. Another thing, you may see these patients that they've already come to transplant with an LVAD, a left ventricular assist device, and this is a tube going from outside to the heart. So sometimes people go in with a known chronic driveline infection. Sometimes the organism. We've had Pseudomonas, we've had Mucor, and it's a challenging situation, but it's not a contraindication to transplant. Because think about it, you're gonna remove everything with the LVAD and the heart, and then you're gonna put a new heart. But again, it's not easy to sterilize things like that. So these patients will go in a specific prophylaxis based on what they came into that transplant with. So this is just some stuff unique to the heart. Other things that are also have a heart predilection, as I said, toxo. You can see the parasite in the if they do a biopsy, if the patient is known to have a donor who is toxopositive and they're not on treatment. Nocardiosis, Chagas, if the donor had certain risk factors. And I want to tell you, we used to think, Chagas can be transmitted only from donors who are from South America. because there isn't like really the transmission in the United States. But there was a case a few years back from UF actually, when the donor has never been to South America, but he was born to a mom who grew up in South America. So it has a so now we screen all donors for Chagas. Doesn't matter if where they're geographic, because you need to know about that. You need to follow PCR and get treated and prophylaxed. Nocardia has a special appearance. It has these nodules, abscesses, and once if you suspect it, you're going to scan the whole body. It's going to scan the brain. You want to take a biopsy and make sure the micro, and these are just pictures of the lung filamentous gram-positive beaded organisms, and that's a autopsy, lung autopsy. So usually we use Bactrim to prophylax PCP, but if they're not given daily, then it may not be adequate to nocardia. So patients on PCP prophylaxis 3 times a week or whatever, they can come in with nocardia, but you're hoping that it reduces the incidence. And we talked about Chagas. The way you screen for it is for parasitemia PCR. If the donor is known to have had Chagas, maybe that's the cause of their heart failure, or they've lived overseas in areas, then at some transplant centers at specific intervals, they may get Chagas PCR. These are just things heart related, but you want to be aware of, because that's how deep you're going to go in your history and what has been happening with the recipient before. And sometimes you need to know also information about the donor. That usually the transplant coordinators keep records on who was the donor. Sometimes it may not be enough. You have their serology for sure. You have their blood cultures before they die, because that's a routine thing. OPOs do blood culture at the time of procurement of organs. But sometimes that's all. You may not have a lot of social history unless the donor is known to be a high risk, because the recipient has to sign. Like what if they are like IV drug users, but they are all negative serology, or they have certain high risk. So,
For
all
those
right.
interested in Chagas, there is a new investigator who just joined the College of Public Health 2 weeks ago, named Dr. Rodriguez, who actually can do PCRs and serologies for Chagas, and he's trying to set up some collaborations. So if you think Chagas, you don't remember his name, he's Dr. Rodriguez, just email or call me, because he'll actually do the PCRs, and he's evaluating risk for all. So he just started.
That's good, because I think, I don't know.
He also works with Norm Beatty at UF.
And there was a cardiologist who interested. I think he was talking to Dr. Rodriguez.
Yeah, but Joel's gone.
Joel's is gone. Okay.
Just
He-
at Lakeland.
He left Lakeland. Okay, fine. Because he was thinking to collaborate with somebody and screen all our recipients and potential donors for Chagas by just to see what the heck. Because you will be surprised. A little story. During my fellowship, actually, that was like a long time ago. So we did not use to screen university donors and recipients for strongyloides. This is coming later, but and in that lecture for screening prophylaxis. But then there were like a couple of cases where strongyloides has been a problem, and there is no really epidemiologic exposure. They're not been traveling, they're not from areas, and then we started, before it becomes a law of the land that you have to screen everybody for strongyloides, taking serologies of our recipients. They had no risk factors, they're from the States, and 5% tested positive of people who had no risk factor. So that's a 5% potential of a very fatal, overwhelming infection. And then it made sense then to screen everybody, because the prophylaxis is so easy and so effective. It just makes sense that even though the number is like 5%, and then the outcome for the recipient is so big. So things like that are very important. But we'll contact him, because I think there was this project of
Anna's already doing it with BMT folks.
Oh.
At Moffitt. But he's definitely interested in doing work down here as well. And I don't know, his staff is down the hall from me,
very
something like that.
nice.
But he's got a strong background in clinical micro, but he wanted to do more research, which is why he came in. He was at Mount Sinai. So we'll get him in later. But if it ever comes up in this specialized population, I can get you in contact with him.
Fantastic. One last thing, also peculiar to heart. They suffer trauma to the tricuspid valve and the right ventricular endocardium because they get the way they follow these patients that the graft is good and want to intervene when there is early rejection is by doing these caths and getting the biopsies and all that. So some folks will end up with a cardiac valvopathy, and of course it's a high risk for infection. So it is, if you remember from indication to prophylax for endocarditis, it's one of them. So they can have endocarditis with like unusual organisms, but also we prophylax against them. All right, guys, moving on to lung. And sometimes it's lung heart, right? Sometimes they transplant both, but for lung transplant. So in my experience, these are the most problematic people infection-wise. And why is that? Because the lungs, they're breathing, is the only non-sterile graft. I mean, if we give, a kidney or a liver or heart, supposedly you're putting a sterile. So there's nothing sterile about the lungs. So what would be the commonest infection for lung? Yeah, pneumonias. Again, the mediastinitis problem. They're very prone to invasive fungus and CMV. So you get a lung transplant, look in the lung very well, scan the lung. If you see nodule, new nodule, or anything, you want to get a diagnosis quickly. Also, they often they are colonized with MDRs because who gets lung transplant? Your, mycobacteria patient or your CF patients, and sometimes if they have bad organisms, they get a double lung transplant because you want to get, but still not a sterile field. And if somebody gets a single lung, then that other lung with everything that's sitting in it. So invasive molds are very much to be beware of. This is a classic aspergillus, right, with the cavity on the crescent sign, they call it. And then after, usual, your invasive fungal CMV. CMV, and this is, I think Dr. Mayer has a whole lecture about CMV. You can talk 2 hours about CMV, but what you need to know that CMV, of course, is a herpes virus. It's a latent virus, can reactivate whenever it wants. It can cause from asymptomatic all the way to severe disease and potentiate rejection. You can follow by the PCR, quantitative PCR, but really to diagnose pneumonitis, or you need a biopsy. And then there are several ways how people are trying to mitigate that. We're going to talk more about that in the second part of the lecture later. How are we going to try and prophylax and prevent CMV? That by itself also is a very complicated situation because if you use too much of the valganciclovir, sometimes you select for resistant viruses and such. The best thing when you're faced with CMV, you get a biopsy, you make sure that's what you're dealing with, try to reduce the immune suppression. There is a role for cytogam, which is the specific CMV immunoglobulin. In addition to your antiviral, there is some evidence that it may improve, morbidity, actually. There's really no set time for how long you're going to treat. You follow by the clinical syndrome and the titers for your best estimate. The issue is the treatment side effect. Once you prescribe the valganciclovir at the valve site, you look at the kidney function, you look at the bone marrow, and sometimes the treatment will be successful, but you can't continue it because of significant side effects. If you're having trouble with controlling the disease, the next step is to check for ganciclovir resistance, and it is done here. They can process it for you. Next option would be foscarnet or combination therapy. Some people use foscarnet and ganciclovir, but the limitation is the nephrotoxicity. It's not a matter of if they are going to get nephrotoxicity, it's just when they're going to get it. And then there is a lot of salvage therapy, marabavir, leteromivir, which is approved for prophy, but some people can use it in combination to control disease. But as I said, you want to be aware of it. This is like just the landscape of CMV, but it's a very, very, it has its own thing, and because it's also common. Respiratory viruses are also very common in lung transplant patients. So they come in, the immune compromised panel that has, it's really meant for these patients. They're not meant for just immune competent folks coming in with cough, and they screen for all kind of pathogenic viruses. We've seen, influenza is a bad deal, COVID-19 or SARS-CoV-2, RSV. There are now indications for vaccination for RSV in adult population. We still follow the CDC. We haven't, maybe some transplant center decided to vaccinate all their potential lung transplant, and I think that's fair. But at this time, this center follows the CDC by age and all that, and now there are indications for adult population. Mycobacterium abscessus, all the mycobacteria, the MAC and all that are problematic, but this bacteria in particular is difficult to treat and has prolonged treatment and sometimes can be resistant. Generally speaking, if you have a very resistant, nasty Mycobacterium abscessus, then you may reconsider transplant because it's going to be there after. So you want to deal with it after with an immune suppressed patient. So pros and cons, right? But the other atypical mycobacteria like MAC and all that, they're not a contraindication. You can go into transplant and treat them afterwards. Some stuff unique to the lung, dehiscence when they do the airway anastomosis. And Dr. Montero is not here. When I was a fellow, we were treating somebody who had mucor, and they had a little dehiscence. They went in a few times, they fixed it, and they came back, and he had mucor infection at the anastomotic site. It was very, very difficult situation. But the issue with lung, that they get these repeated pneumonias and all that, and they end up with something called bronchiolitis obliterans, which even predisposed to more infections. So 5 years out from recurrent infections, they usually lose the graft, 3 to 5 years. How people try to predict what's happening and prophylax and all that, the lung transplant get BL surveillances, very frequent at the beginning, and then as they kind of devise some sort of a follow-up. But you have to go in with a BL, look at all the airways, take biopsies, take swabs, so you kind of stay ahead of what's going on. All right, guys, liver. What kind of infections? Intra-abdominal. So common things are common. They still can come EDIs, pneumonias, but they come in with fever, not feeling well. That's where you're looking first, and it occurs frequently and it occurs early. Sometimes they're still in the hospital and you're starting having cholangitis and fluid collections and things like that, biliary tree, surgical wound. So belly, but still they can get bloodstream infections if they have lines, and of course pneumonias. A organism that loves kidney transplant patients is Candida. And that's why it's one of the solid organ transplants that, we will learn in the other lecture that the antifungal continues longer than the other non-lungs. Of course, lung patients, they stay on mold prophylaxis forever, but liver, you're going to keep them for quite a while, that first 30 days or longer on antifungal like fluconazole, or because they're very high risk for fungal infections. They also are at risk for molds, invasive aspergillus. You wouldn't think, but that's one of the organisms that you kind of have to keep in the back of your mind, like molds, invasive molds. Sometimes it's difficult to culture, but if you see, a mass, or they're persistently ill, or sometimes we go as far as getting a bone marrow biopsy to kind of try and find what the culprit is. And I will not be surprised if it is, something like a mold or disseminated candidiasis, because that's where the population that this actually happens. So Candida, Aspergillus, Cryptococcus, and remember, Cryptococcus in specimens and in blood will be read as yeast. Sometimes the patient will be started on mycofungin, and appropriately, because again, 70% of the fungus is Candida, but sometimes it's Cryptococcus, and that does not respond to mica till you get further identification.
That yeast by accident. That's how it appears.
Well, it's a yeast. So the blood culture will tell you yeast seen. So people automatically think Candida, but it is the other yeast, Cryptococcus, which is this is why, when you approach this patient, that they can have yeast, but it can be Cryptococcus. That's you're sending the cryptococcal antigen, or once you see yeast, you're kind of calling the lab or you're covering for it, because now it's the probability that it can be Cryptococcus. The other patients, AIDS patients, they come in confused, febrile. They call you blood culture positive yeast. They are on micafungin and disseminated cryptococcosis. It's the patient population that this happens in. So AIDS definitely take the prize in Cryptococcus, but then liver transplant recipients can have yeast in the blood that's Cryptococcus. But Candida by far is what you will see most commonly. So why this happened with liver? Because it's usually long. It's a very germy type of operation because of, they're near the colon and, all that stuff. Translocations happen. So you will see liver abscesses, cholangitis, peritonitis, abdominal abscesses. That's why, you're kind of scanning and sampling any fluid that you see if that is detected. So as you can see, the management in general, when you see these patients, after you say, well, I need to get the accurate microbiology diagnosis, I need to know the extent of the infection. Is it, disseminated? I need to get them on quick empiric. The next thing you're looking, are there any things that need to be resected, drained? Sometimes grafts that are rejected, they're so rejected. I had a patient like that. The liver is technically dead, but it's sitting inside, and then they have all these abscesses and things. So sometimes they may need to go for a retransplant. Or if there is a collection, you're gonna ask for drainage. You're going to use appropriate microbiologically guided with susceptibility antibiotics, but many times they do need prolonged courses and then followed by some sort of prophylaxis, unlike your non-transplant patient. And then when all fails, we've had patients who received a retransplant just purely because of the organ is just so severely infected that it's not feasible to, although retransplant is usually seen for graft failure and or ischemia and things like that. So these are like the mainstay of the approach. One last thing, I always speak about COVID-19 because things kind of evolved over the years. When COVID first appeared in 2020, 2021, we weren't transplanting these people, we weren't taking organs from them. Now we know that the only risk that an organ that transmits COVID is lung. If patient had just had COVID or recovering from COVID and died for whatever reason, or if they died from COVID, they have perfect kidneys, take the kidneys. You're not going to transmit that to the recipient, and you do not need to prophylax the recipient. For lung, however, there has been cases, and sometimes people had asymptomatic COVID, but they had the virus sitting down, and that's why we accept lungs only from people who had BALs and SARS-CoV-2 tested in the BAL, not a swab, not so these donors are screened. The recipient is also screened. You don't want to transplant someone who's like fighting COVID. Usually you try to, or fighting an infection, right? But it's not a contraindication to transplant. And then the clinic, now we know that the disease may be a little bit more severe in transplant patients, but the diagnosis and the treatment is kind of similar approach. It's the same drugs, but you have a lower threshold to start antivirals in your transplant patients infected with COVID. Always discuss the immune suppression, see especially if they're moving towards like a COVID pneumonia or something. And then, of course, the vaccination schedule follows the regular population vaccination. And I think that's it. And sorry, I talked too much, but it is a very, very, yes, question.
When you said like they screen through BALs, that's like a postmortem BAL?
So for donation, you have the people who are like, the vast majority of donation takes place on people who are brain dead. Did anyone read the New York article recently? check it out. But so supposedly the person is brain dead, vegetative. They did a brain dead protocol, a neurologist, an intensivist, and all that, and said this person is not going to wake anymore. Then the organ procurement folks, gets involved. They do their thing, their screening and all that, but the donor is still intubated in the ICU, managed fully, because now he has, say they have a hemorrhage. Let's say that all the organs are great. He has potentially for heart, lung, kidney, liver, pancreas, small intestine, other than the tissues, skin, bones, ligaments, corneas. That's gonna benefit a large amount of people. So these people are kept, managed as if they are alive, not brain dead, right? Till they go to the OR, everything is set up, and then they get extubated. And once they see asystole, that's when the organ start. The BAL happens when they're still in ICU, like the day before or the procurement. So the person is alive, and you're doing the screening, you're sending the HIV, the hepatitis, you're doing the BAL. If the donor is not a candidate for lung, they may not do a BAL, but they may for kidney, for example, if they are good only for kidneys, then they may or may not screen for COVID, but because now we know it's irrelevant, nobody asks about it. But if they're going to donate kidney, lung, then they have to do an BAL with the whole thing, because you need to know they have to be COVID negative, RSV, influenza, they have to be negative in that. You don't want to take but let's say you transplant the lung, and then the 2-3 days later, their culture is growing Pseudomonas or staph, and now you're prophylaxis the recipient. So it's the BAL is only indicated if they're transplanting lung for screening purposes. Now, if you have a donor and you're going to take a kidney, but they have a big old cavity in the lung, you need to know, because to accept the kidney, you want to make sure that you know the infection risk and you're prepared for it for the recipient. You do never accept an organ when somebody is fighting an unknown infection or they have something that is undiagnosed. That's kind of the rule. But the COVID thing, any detection of COVID in a BAL, the lung is not accepted. That being said, again, and that's why I keep updating this slide. I mean, at this time, previously we didn't accept anything. Now we said only lung COVID positive. And I think now they're talking about finally using the cycle threshold and all these things, which before nobody even want to talk about. They said, don't go by cycle threshold, because these are still immune compromised patients and so forth. So, I mean, I think we stop here. Any other questions? Yes.
Regarding cruciae being risk factor transplantation, there was that recent report from UF researchers that suggested that about 30% of the triatomid bugs in Florida actually harbor pathogenic trypanosoma cruciae. So it's definitely out there. It's a risk.
That's impressive.
The entire Southeast, Texas as well, because that's another place that they've looked.
They have
entire Southeast.
So we have the bug and the organism, and it's matter of time.
There are species barriers,
yeah,
right? So the ones they don't seem to jump easily, but that's what they say about a lot of organisms until they jump.
Yeah,
right?
That's true.
So like West Nile, things like that. But it's not just Florida; it's the entire
Southeast.
Yeah.
And that makes sense because, especially with global warming and stuff, I mean, we've seen things, chikungunya and all these things 20 years ago, now there are like cases in South Florida. So you have the vector, the bug will come and then it will start appearing and once it appears in 1 or 2 transplant patients, then, you get the screening to be more, the thing that baffles me, because, that's the thing. Donors are not screened for HTLV 1 and 2 consistently. They're not.
People aren't always. They should be screened for toxo too, and they're not always
Yeah.
screened. Both donor and recipient.
Yeah.
Because
True.
That's my area. And, you know, we have cases of this like every year because the toxic prevalence is so high around here. And you know, the antibody serologies are frequently pretty low. So you really need to screen people before you immunosuppress them. And a lot of times it's not done.
Yeah, it's just until it actually happens and somebody dies. I think that's when, oh, okay, well now it's going to be the law of the land. Like you have, like now the RC, it's FDA regulation. You have to screen every donor for HIV, hepatitis, B and C, syphilis. What else? HIV, hepatitis B and C, RPR, syphilis. What am I missing?
I don't, but
That's-
toxins
that's
not
it.
required.
No, this is.
Like strong gates, yeah.
No, this is FDA. FDA. No, that's FDA requirement. But all these other things, you know, people are just figuring out that, okay, for matching, for prophylaxis, you have to do the CMV, the EBV for organ. But things like HTLV1, sometimes I see them, sometimes I don't. Now the prevalence again is very low, but I mean, this is such a serious. I wouldn't want to take an organ from somebody who's HTLV1 positive because of the. So that's it. And then the other big thing, which is creating a huge controversy now, we do screen recipients for TB, latent TB, because you have a semi-reliable test, the quantiferon. We don't test donors because the quantiferon is not. There are no trials in people like brain dead. You know, the immune cells and all that. So we don't know the reliability, like the false negative rates and all that. So the company said, well, that's we cannot say it's. So if you use it, it's going to be outside the. But we do not screen for TB for donors, and you know, there's really not a great test. But that lung, when they get the BAL, the culture goes for fungus and AFB. So you will know if they have like an active TB. But again, cultures are extremely specific, but they're not that sensitive, especially if somebody has like low bacterial load or and of course will not diagnose latent. So you can take an organ with latent TB and then eventually.
You have to remember our epidemiology is different than most of the country. We have more sort of hybrid developing world epidemiology as far as exposures. Like you can get strong D here. You have more people who traveled, are immigrants, you know, things like that. So our prevalence for all these things that's low in the rest of the country is actually much higher here. Plus our climate is different. So things that you read from fancy places in the Northeast or the Pacific Northwest, maybe the epi is not the same as here. Agreed.
And we are the mycobacterium capital of the world. Like there's just so much mycobacteria. Like if you're not sure what it is, it's one of the mycobacteria. It's one of the mycobacteria. Just wait.
I just got an M. consult yesterday.
Yeah, it's
someone on the long transplant.
Yeah, that's bad news. Yeah, that's bad news. So I mean, this is just this is not meant to be part of the, but you know, for the diagnostics for these immune compromised patients who are really, you know, you get the biopsy, you get the path, you discuss with your pathologist because you're kind of telling them, okay, you look at everything, but I have specific concern about this thing. And sometimes they'll call you back and say, you know what? Yeah, that's, and then there is the PCR technology where you can test for a battery of like fragments of DNA from organisms, but in the right context, in the right clinical syndrome and all that may give you a head start prior to cultures or things like that. So I think it's a great utility, but you have to really kind of spend time, try to explain it. And because also the last thing you want to do is follow something that is not really accurate. So you kind of keep an open mind, you interpret it in what's, you know, in context and then decide to intervene or not. But I mean, just my personal experience from a few patients, it was accurate. I mean, it did, you know, we had a lung transplant who kept just coming up with this febrile syndrome and a little bit of leukopenia. I mean, she had the workup. And then I didn't think about it, but I got the carriers and she had a large number of HHV6. That was her thing. And it turned out to be true. That's what it was. So, and several other cases that I thought was helpful and actually did help. Some situations it wasn't really conclusive or didn't make sense. Another patient who came from after being in like so many hospitals, a liver transplant and many strictures and things, and she had a higher level than for M. abscessus. I mean, we kind of went back and forth, but it made sense. She had so many ERCPs and so many procedures and stuff. So that was also another kind of, and expect this cultures kept coming back negative. But
What do you do with that though? Like, how are you going to empirically?
that was the most difficult. That was the most difficult case. But we had a long. I mean, she was going to like a year after, and every time they biopsy it, it's inflamed. She has a little bit of like fluid and all that. I think I don't recall exactly what, but I think we decided to follow up and do like a follow up on the titers or something, because I mean she had significant levels of M. abscessus. That was the only thing that kind of stood out. All right, guys. Well, thank you so much for your attendance, and I'll see you down the road. Hopefully we can talk about prophylaxis.